talk about actually is nothing very sexy at all. Not that you can really make any of this very sexy, but it's going to be not about tissue repair and wound healing, not about reconstruction, but it's going to be what happens in between and how to maximize time and those ulcer-free days, hospital-free days, activity-rich days, if you will, in between wounds for this patient population. So ladies and gentlemen, this is what I do for a living. I am a toe doctor. I'm just a foot doctor, a toe mechanic, as it were. And you know, oh, by the way, my father, I don't have two generations, I only have one. My father was a foot doctor, and my daughter, our oldest, Alexandra, is going to be a third generation one, so I'm trying to do right. And actually, my old fellow, Lee Rogers, is now her chief. So you see about personal and professional progeny. But anyway, looking after the foot, I can think of two gifts in tending to the foot, and I think they're both really important. And the first is that in this era of kind of chest thumping and a kind of braggadocio and hubris, I can't think of anything that's more of an expression of humility than looking after someone's feet. You know, this crosses all borders. Frankly, I think it probably crosses most religions, and if you think about it, even time, right? There's nothing that puts you in a position of humility like looking after someone's feet. It doesn't matter what you did before you looked at it. It puts you in that position. So there's that gift. And then the other great gift, I think, my father used to tell me the best gift you can give anyone besides your love is perspective. And there's this great gift of perspective in looking after the foot. When you're out there on this peninsula, this anatomic peninsula at the end of the body, it forces you to collaborate, medically, surgically, kind of mechanically with the anatomic mainland. And what's so much fun now, I think it's the most fun time to be a foot doctor, is that we're doing so many things from spread-on skin to spray-on skin to even wearable robots. We'll talk about that later this evening, to even brain-computer interfaces now. It's a really fun time to be doing a lot of this work on the perspective side, but unfortunately on the humility side, there's a lot to make us humble. This is the first video ever caught on tape. It's from my friend, the late great Professor Kel Cohen, who is a great plastic surgeon, one of the fathers of the Wound Healing Society. And check this out. This is Professor von Bergman doing the first surgery ever caught on video. This is 120 something years ago now. And look at that guy on the left, for sure maybe a fourth year student, super excited to be there. And then you see the guy in the middle, that's like the fellow. Who am I? Am I the attending? Am I a resident? Where do I belong? The nurse there, you know who she is. She's the QA nurse, and she's upset the professor is not wearing gloves. Didn't get the message from Mr. But she's very happy. He turned the room over so fast. But the learning point is not what's going on this video. The learning point is what's happening kind of off video to this woman or this man having her or his leg off like 123 years ago. And she or he probably had a better outlook on life than someone right now in India, in South Asia, in the EU, in North America, or really anywhere around the world. And I think that stinks. And I think there's a lot we can do about it as a family, surgically, medically, and mechanically, if we just add a little perspective with our humility. But let's continue on with all the bad stuff before we get to the good. I don't need to tell this family here that complications of the foot they're common, they're complicated, they're costly, and I guess that's kind of alliterative as well as bad. But let's just look at these data. These data are not dissimilar in North America to what they are in South Asia and in India specifically, but in the US, maybe give or take about 10% of our population have maybe 35 to 38 million now have diabetes. And of that, and you've already heard this from Professor Campbell, about half will develop some degree of significant neuropathy, and about half will develop the most generous definition of peripheral artery disease. And then maybe, if we see here, there's probably a couple of million living with active wounds, severe peripheral artery disease, like now called CLTI, chronic limb-threatening ischemia, or just with frank limb loss. So those are the data. And I think they're fairly similar around the world. There's some modifications, but if we're looking at the big scheme of things, that's what we can look at. And we didn't believe these data when we first looked at them. I'll just share this with you. We looked at the global burden of disease in diabetes across the world, and you see here, let me see if I have if this works. Is this the, oh, here it is. Okay, let's see. Oh, there we go. Can you see that? My hand, it's good that I took a data block beforehand, so my hand's not shaking. But if you see here, if we look at these top 10 conditions from the World Health Organization's global burden of disease, what we see is when we disaggregate the lower extremity from the rest of diabetes by itself, these feet are a top 10 condition. It's crazy. And now this is getting worse, not better, around the world. And we can continue looking at these data from the same data set just a few years later. And we looked at this, and in every part of the world, for every lower extremity complication of diabetes, this is getting from the thin to the fat kind of histogram here. This is getting more common and more complicated. And even in parts of the world that had in the last decade reported some reduction or leveling out of high-level amputation, which you see here, this is from Amadou and co-workers in France. So this is what you see in this bottom portion of the graph. But if you look up here, even for them, what you're seeing at the top is an increase in diabetic foot ulcers. So it's a little bit like maybe a generation ago, we started to have fewer cancer deaths in terms of per person, but more people living with cancer. It's kind of what we're seeing now with diabetic foot ulcers around the world, not just in France. Let's keep on keeping on, because this problem is, as I said, common and complicated, and it's frankly really morbid. If you develop a diabetic foot ulcer, with the best available data we see here, there's about a 2.5-fold greater risk that you are going to die that year than all else being equal if you didn't have that diabetic foot ulcer. So let's keep on with this cavalcade of complexity and bad. And look at this. We looked at like a 2.5 or something like, was it 5 billion outpatient visits across the United States. And what we found was that we looked at complexity really, which is just emergency department admissions and referrals and number of visits per year. And for all these problems that we know are important, like having renal disease, or like having a heart attack or a stroke, or COPD, these are all very, very important from a public health sense. But look at this, diabetic foot infections and foot ulcers, I think we can safely say, are at least as complicated as these other terrible problems that we see. It's just that they're largely ignored because they're at the end of the body and they're covered up by a shoe and a sock, which makes them doubly sinister. So let's stick with the bad now for the next maybe 5 or 10 minutes, and then I promise you for the rest of our chat together before you go to lunch, it'll be all good. So how do we describe this maybe to a non-medic or maybe to a health minister or to a family member? Well, here we go. Maybe we could just say now, every second, someone with a diabetic foot, someone's going to develop a diabetic foot ulcer somewhere around the world. About half of those are going to get infected. About 20% of those infections, give or take, will end up in hospital, which is why now around the world, every 20 seconds, someone is going to receive some level of diabetic foot amputation. And that's, again, something that every 20 seconds, we'd like to say that, time's up. And we can reduce this, and I would argue even eliminate preventable amputations over the next generation if we just work together. And you see these efforts here at the MV by looking at the wound healing training program, where we're training the next generation of women and men who are going to be nurses and doctors caring about this problem. This is the way forward, frankly. So, again, I'm sorry for the bad, but let's just get a little bit more of this before we take our medicine before we see the good. It's not fair to compare one terrible thing to another, but the fact of the matter is that we all care about cancer. We've all had a family member that has survived or has succumbed or is living with cancer. Very few people outside of this room care very much about diabetes, and even fewer care about feet. So, but let's just compare this as an academic exercise, not nothing more. Let's first look at the cost. These are data from us and from Neil Barshis from the DeBakey Department of Surgery. And this is already more than a decade old, but I left it in because it was the most conservative, not the most aggressive number. In the United States now, and this is even more true now, diabetic lower extremity complications are more expensive, again, more expensive than the 5 most expensive cancers. And this is also true in other parts of North America, like Canada. It's true in the National Health Service in England and also in the EU. So these data are crazy. And then look at this, even more important. Look at mortality. Now, there are plenty of people now that are dealing with and living with breast cancer and lung cancer and all of these terrible problems. And we would never think of withholding therapy on one of them. But this kind of pessimism and nihilism happens all the time in people with wounds or other problems. We say, oh, that woman, what a poor lady. She has that wound. She's just going to get another one. Why don't we just chop her leg off right now and be done with it? And for some people, that's probably the best treatment. But I think the data are now becoming quite clear that that's a vanishingly small minority of many of our patients. And I think it's getting smaller and smaller. The good news is, as we put these teams together, not just in India, but around the world. But the good news is that we have to fight this sort of nihilism. And that's what's happening now in units like this and in countries like this, with families like this kind of getting together to make a difference. And then if we continue with this analogy of cancer, health-related quality of life with diabetic foot ulcers is worse than recurrent breast cancer, not even regular breast cancer. So here we are. If we're living in simile and metaphor, it's really terrible. So just this last year, we had this paper in JAMA. I showed that New England Journal one earlier, but this one kind of took a larger look at this in terms of the most current data. And let me just show you, because we've already talked a little bit about how these wounds develop. What happens is these people develop, you saw this all this morning, they develop sensory neuropathy, so they can wear a hole in their foot like you wear a hole in a sock or a shoe. They develop motor neuropathy, which makes the big muscles of the foot, of the leg, overpower the small muscles in the hand and the foot. And so you see these intrinsic minus deformities, which gives them, I don't know the medical word for jacked up, but you know what I mean, kind of a jacked up foot, which gives them deformities and fewer cycles of stress before the skin breaks down. Autonomic neuropathy makes their skin more likely to be friable. Their skin turns from more like a tortilla into more like a cracker, to use a culinary analogy. Viscoelastically. And finally, PAD, peripheral artery disease, just by itself is a bad actor, and when you add it in, everything gets worse. And this is just the big picture in this repetitive stress kind of problem that leads to shear stress and normal stress, ultimately subcutaneous kind of hemorrhage, and then callus over that, and then that callus is often hiding an underlying ulcer, which is why these things have to just be debrided off aggressively to try to offload this over the course of care. So not too long ago, Professor Bolton, Sicko Bus. By the way, what a great name, Sicko Bus. So my longtime friend and to a lesser extent me, we looked at not only wounds, but we looked at more importantly, their recurrence. And speaking of humility, let's look at these data. Because after 1 year after healing, about 40%, with the best available data from our unit and from others, 40% are going to have a recurrent wound. It's about 2/3 at 3 years, and give or take 3/4 at 5. So recurrence in this patient population, ladies and gentlemen, is not only common, it's darn near likely. So if the foot in diabetes in the most, again, humble sense is a little bit like cancer in terms of its epidemiology and such, then maybe when a person is healed, maybe they're not healed. Maybe they're really, I would say, in remission. And this may seem like a turn of phrase and just words, but I assure you, it really means something.